Medullary carcinoma thyroid is a neuroendocrine tumor derived from C cells, formerly known as parafollicular cells, of the ultimobranchial body of neural crest, which secretes calcitonin. It comprises of 1 to 2% of thyroid carcinomas. They are either sporadic, non hereditary, or familial, hereditary. 70% of the cases are sporadic, and the sporadic cases are usually solitary and affect the age group between 40 to 60 years. The familial one comprises of 30% of the cases, and it usually affects younger patients, mean age 35. The familial ones can be due to multiple syndromes like MEN2A, MEN2B syndromes, familial medullary thyroid carcinoma syndrome, von Hippel-Lindau disease, or neurofibromatosis. It is caused by gain of functional germline mutations in the red gene. These are usually bilateral multicentric with C cell hyperplasia and are usually discovered by screening tests for serum calcitonin or peripheral blood red oncogene mutational analysis. The medullary carcinoma thyroid patients present with painless thyroid mass, which is colon scanning. Up to 75% of patients have nodal metastasis, mostly involving central compartment, ipsilateral and contralateral jugulocarotid chains, and 10% have distant metastasis. The serum calcitonin on studies have been seen that it correlates well with the tumor burden. Patients with metastasis may have severe diarrhea and flushing, and some tumors may produce ACTH or corticotropin releasing hormone causing Cushing syndrome. Coming to the gross description of medullary carcinoma thyroid, the sporadic ones are usually single, circumscribed, and non encapsulated gray tan mass. The familial ones are generally bilateral, multifocal, with solid gray tan yellow firm and may be infiltrative. Larger lesions have hemorrhage and necrosis, tumor usually in mid or upper portion of gland with higher density of C cells. If the size of the tumor is less than 1 centimeter, then it is known as a microcarcinoma. Microscopically, there is a wide range of morphology and can mimic any other thyroid malignancy. The tumor cells are round, plasmacytoid, polygonal, or spindle cells in nest cords or follicles, often mixture of these cells are seen. The nucleus is round with finely stippled or coarsely clumped chromatin and indistinct nucleoli with occasional nuclear pseudoinclusions. Eosinophilic to amphiphilic granular cytoplasm due to secretory granules. The mitotic figures are generally low, and the stroma has amyloid deposits from calcitonin. Sometimes samoma like bodies can be also encountered. In this micrograph of medullary carcinoma thyroid, you can appreciate the amorphous pink substance, which is the amyloid interspersed between the tumor cells. Going on a higher magnification, you can see these tumor cells are polygonal with finely stippled chromatin, and in between the tumor cells, you can see there is deposition of amyloid. Coming to the cytological description of medullary carcinoma thyroid, these specimens are cellular with round, ovoid, plasmacytoid, or spindle cells, single or in small clusters, and these cells have abundant cytoplasm and eccentric nuclei with salt and pepper chromatin appearance. They may have pink azurophoric granules and intranuclear pseudoinclusions, and amyloid is present occasionally. In the inset, you can see the counter stain by calcitonin immunostain, which is taken positive in case of medullary carcinoma thyroid. The treatment is usually total thyroidectomy with cervical lymphadenectomy for node positive patients, and the 5-year survival rate is from 65 to 90%.